Obviously cutbacks here. So thank you very much for the invitation. As was mentioned, I'm a family physician and I'm quite privileged in that I work exclusively with refugee populations. I spend most of my time at Women's College Hospital where we have a clinic in place that serves newly arrived refugees. And I spend 1 day a week in a refugee shelter. So we're seeing people very soon after arrival, often within the first few days. I was asked to speak about deciphering these recent changes to the Interim Federal Health Program, the health insurance program that's run by the federal government and covers insurance for all refugees in Canada. It really is deciphering the undecipherable, but we'll see how far we get. They've been immensely complex, and certainly that's translated into a lot of people struggling to find out who's covered, who's not. And I'm afraid people have also been denied care, sometimes unnecessarily. So just as a bit of a background, are all of you familiar with the Interim Federal Health Program? Yeah? Okay, so it's a program that's been in place since 1957. It's run by the federal government, as you know. Generally, health is under the mandate of the provinces. Refugees are a bit different. And it's a program that historically has provided similar services to what you get on OHIP. That allows access to clinician care, laboratory tests, diagnostic care, so you can get x-rays, blood tests, things of that sort. It also provided access to care in a way similar to people on social assistance. So you'd have access to medications, occupational therapy, physiotherapy. And it's been in place again for generations. As of this year, there was an announcement on April 25th that suggested the government was making major modifications to the program. And in fact, it was put through as an order in council. Most of you would be familiar with Bill C-31, which came into play just a couple of months ago. Although it dovetails a bit with what's in Bill C-31, it's an order in council. So that's a very important distinction because it didn't have to go through parliamentary procedures to have it implemented. And similarly, if there are changes that are going to be made or if the changes are revoked, it again doesn't have to go through parliament. This can be by order. And it is coupled with some of the changes in Bill C-31. Probably the most notorious thing is the implementation of the designated country of origin list. Okay, so to understand these changes, unfortunately, we have to understand refugee migration to Canada and the different groups of refugees that we see here. Now, as academics, this probably is not unfamiliar to you. I'll say is most physicians will have no idea about any of this. They don't want to have an idea about any of this, and unfortunately, part of understanding this policy is that we do break refugees down into different groups, and this we will be responsible for knowing this as clinicians. So as most of you know, in very simple terms, refugees can be broken down into two groups. These are people who've arrived in Canada and have been given refugee status pre-migration. So these are folks who are identified before they get here. They often go through the immigrant health exam, pre-migration. They get here, they're given OHIP on arrival, they're on the trajectory to become permanent residents, right? And they fall into really two large groups. The first are government-assisted refugees. So these are people who are supported by the government. They get a monthly stipend, which is very similar to what social assistance will provide you for most of them for 1 year in Canada. The second group are privately sponsored refugees. So these are people where any group of 5 or any institution that has an agreement with the government can sponsor people to come here. Again, they will be Canadian citizens. They're processed pre-migration. They do have a health exam before they get here, and they will have OHIP upon arrival here. Historically, they've also had interim federal help. What Interim Federal Health provided these groups was it allowed them access to medications, it allowed them access to physiotherapy. Many times we'll see people who've endured war, lived through trauma. Not unusual that when people arrive, sometimes they'll need a prosthetic. People have had amputations of their legs or might need a wheelchair. Interim Federal Health was able to provide that for those two groups. And the other large group, sorry, just to give you numbers, there's about 8,000 government-assisted refugees that come to Canada. It's been between about 7,000 and 8,000 for quite a while right now, at least the last 10 years. Privately sponsored refugees, we're looking at about 5,000, right? Ballpark figure. So somewhere around 12,000, 13,000 people would be resettled refugees, which is the term that the government is calling. The other large group are called refugee claimants, and these are people who, of course, find their way to Canada. Often they come from countries where a visa is required, or people who come with visas and decide to stay. They make a refugee claim. And when they make that claim, it takes about, at this point, it's taking about 18 months for that claim to be processed on average. That group will be divided into two large categories. Those that come from designated countries of origin. Okay? The leaders refer to those as so-called safe countries. That list has not yet come out. And then all the others. Right? And although we don't really have a sense of who will be on that list, I think most of us feel fairly confident that all European countries will be on that list. Mexico will likely be on that list. Other countries in Latin America might be, the Caribbean perhaps will be. And then of course, for refugee claimants, once they go through their hearing, there is a process of review at the federal court, and if that's denied, they fall into a group we call rejected refugee claimants. Okay? And we'll see how this sort of pans out when we impose the interim federal health coverage on top of these categories. Okay, so historically, as we said, it was quite simple for clinicians. People would come in, they'd come with their IFH certificate, and we know they would get pretty much the same coverage people would get before, right? They could see doctors, nurses, midwives, they could get diagnostic tests, they could get laboratory tests. And we know through the Interim Federal Health Program that they would be able to get access to medications. And the list of medications, the formula is it's identical to the same coverage that people on social assistance would get. It was provided to all refugees, regardless of their category. So to claimants, to resettled refugees, but also to failed refugee claimants until they were asked to leave the country. Okay. In that initial order from 1957, the terminology that was used in that order was that the coverage was for urgent and essential care. And historically, that's been interpreted very broadly. So there's no problem seeing somebody and doing the PAP test or immunizing their kids. There was no need, I think, as a clinician to sit down and define what urgent and essential is. It was streamlined, fairly simple. All right? Okay, so current changes. All refugees, regardless of the category, will lose access to medications, to emergency dental care, to vision care, access to prosthetics, occupational therapy, physiotherapy, long-term care. So all those services that many of us feel are essential, and you'll hear the government referring to them as supplementary services. For some refugee claimants, many of them will end up on social assistance in those first few months in Canada, and some of those services are accessible through social assistance in Ontario. So, for example, if someone does arrive, makes a refugee claim, ends up on social assistance, they have access to a medication formula. Sometimes we can get emergency dental care. It's often on a case-by-case basis. Sometimes we can get physiotherapy. So for people who are not working, who end up depending on social assistance, some of those cuts will be mitigated by provincial coverage. It's a huge issue for refugee claimants that are working. And of course, it'll be a huge issue once that designated country of origin list comes up, and we'll talk about it. The resettled refugees, because they're given coverage, they're given support by the federal government, they cannot apply for social assistance. Okay? So remember that first group of 13,000 people? They cannot access the medications, dental, vision services through social assistance. Okay? So those cuts will affect them differently. Okay, just want to back up a bit. The changes were announced on April 25th. I think Angela will speak to you about some of the advocacy initiatives. They were to take effect on June 30th. So those of you might remember that was a long weekend. I think 30th was a Saturday. On the Friday before that long weekend, at about 4 o'clock in the afternoon, the government changed their website. Right? And they changed their website to suggest that government-assisted refugees will no longer be affected by these cuts. They said that was never our intention. We wanted to just clarify any misunderstandings. There was no formal announcement. Minister Kennedy mentioned it in an interview on CBC television around 4 or 5 o'clock, and the website actually changed later that evening. So government-assisted refugees, that make up about 78,000 people, will be spared all of this. And there was really a sort of last-minute change. I feel quite strongly it was a change, although the government denies that. Done on a Friday before a long weekend. I'm told that's usually how these things are done. So they will not be affected. They will have access to medications. They will have access to emergency dental and vision care. Privately sponsored refugees will have to find a way to pay for their medications. They'll have to find a way to pay for their prosthetics. And a lot of those costs will be taken up by their sponsors. And already there is a challenge. There's a legal challenge that was instituted by the Anglican diocese in Manitoba around that. So we'll see where that ends up. Okay, designated country of origin list. Are you guys familiar with this? Yeah? everyone? Okay, so this is a list that we're anticipating will come out sometime maybe in December, maybe in January, but it certainly is coming. And this comes from Bill C-31, where the government has instituted a different stream of processing for people who come from these so-called safe countries. And although there are objective criteria to how you determine what is a safe country, there is also ministerial discretion. Right? We're quite certain that the impetus behind this has been that large flow of refugee claimants that have come from Hungary, mostly Roma refugees. And we're anticipating that once that list comes out, it will be disastrous. And I say disastrous because when the cuts come into effect, anyone who comes from a designated country of origin who made their claim after June 30th will essentially get no health care. Right? So these are people, if you come, your child gets into an accident, has a fever in the middle of the night, you end up having to have your appendix out or having a heart attack, there will be no coverage. What the government falls back on is that they will provide coverage for issues of public health and public security. Now, the definition of that might be very different than what you and I would define as public health and public security. And in the order itself, they define an issue relating to public health as a communicable disease. It's on a list, a notifiable disease list, the Public Health Agency of Canada, and where there's human-to-human transmission. So if we take that and think about it in terms of our practice, things like malaria would not be covered. Things like pneumonias would not be covered. If any of you are inclined, that's the list. And it's a long, long list of quite obscure things. I mean, there are things on there that we see quite frequently, hepatitis, some sexually transmitted infections. But things like botulism and anthrax and polio are quite rare. So the garden variety of things that we see, someone who comes in with a pneumonia, someone that comes in with a kidney infection, will not be covered, right, in terms of issues of public health. So it's a very, very specific list. They go on to say not only will they cover issues of public health, but they'll cover issues of public security. And that sounds fantastic. Issues of public security, and this is from the order itself, a condition of public safety concern means a mental health condition in a person who's been examined by a physician licensed in Canada, and for which the physician is of the opinion that the person will likely cause harm to others. So pretty much you have to be a danger to someone else. If you're standing on the Bloor Viaduct or whatever the equivalent is around York University and are going to jump, there is no coverage. So very, very stringent criteria of how they define issues of public safety. I guess if you're going to land on something, that would be an issue. In the end, that's all that will be covered for people who are coming from these designated countries. Any questions about that? There's been a lot of banter in the media, and I think the government has put out a lot of messaging around that, which perhaps hasn't been so tight.
In social work field, if person is harmful to him or herself or harmful to others, you have to report to police or authorities.
That's right.
Now, in this condition, when person is harmful to others, not to himself, so himself is out.
Yeah, it doesn't matter if there's
It doesn't matter. But if one to others,
you still have to report.
Legal issue.
Yeah, you
And
still
it's
have
a
to report
police
it.
issue.
So here, let's play it out. So let's say that you see me and you're a social worker or a physician, and I express that I have a desire to kill myself. You still have the obligation to report. Someone will still come pick me up and take me to hospital. I just won't have insurance for it, right? So I will not be covered. I will be billed for it. And that happens where you see that. But also when you release me out into the community, I have no coverage for medications to keep me from being suicidal. Right? Different medications are part of the treatment. So, immensely problematic. And I think, for those of us who practice in Canada, this is, we haven't seen people here through legal channels who are this confined in the health insurance thing. So really, to me, this is a game changer. And we will start hearing those stories sometime in December or January. What are the rationale for the cuts? The government speaks of costs. The numbers that are bantered around is that the total cost of the interim federal health program is $84 million in 2011. They're anticipating a savings of $100 million over 5 years, so $15 to $20 million a year. Many of us question that. They haven't released how they've gotten to those figures. We know already we're seeing people that we feel we could take care of as an outpatient that end up in the emergency room, which is the costliest way to provide care. But in the context of healthcare budgets, where we really talk in the billions, 15 or 20 million is, I hate to say it, it's insignificant. Right? They've talked about being a deterrent to refugees, and this has come up a few times. And I've heard a number of MPs speak about the Roma refugees migrating here in terms of access to healthcare, in terms of access to social assistance. This certainly has not been my experience. Most of the people we're seeing from Hungary, for example, often will come with a number of different diagnoses, bags of medication. I really don't feel that that's been an issue pre-migration. I think they've actually had quite reasonable healthcare. More and more, they've left those first two arguments and landed on the idea of equity. So the notion is that refugees are getting gold-plated health insurance that other Canadians don't have. They've heard from Canadians this is unacceptable, and this is what these changes are about. I think just to speak to that, it is certainly true the person in the corner store has access to OHIP, but doesn't necessarily have access to medications or dental care. Nevertheless, I think it is like comparing apples to oranges. We know that people who are low income in Ontario do have access to Ontario Works, and they had nothing different than what refugees had before these changes. We certainly know after these changes that people will have much less than almost, particularly the folks on that designated country of origin list, much less than any other person who's in Canada outside of that 3-month wait list where people have no health insurance. So, more and more this is the argument that's being put out there, and I think this is the one that needs to be countered. They've also spoken about immigrants getting an immigrant health exam before they migrate here. For those of you that actually may have come through to Canada and had that exam, it's a very cursory exam. It's certainly nothing like what we would do in our clinic. I think most physicians would do it in their clinic. It's really for immigration purposes. It's to rule out communicable diseases. It's to see if you're going to be expensive once you get here. The idea that replaces an annual physical exam or a general physical exam is nonsense. And they've reiterated the fact that we're still covering public health and public safety issues, and we've spoken about that already. I know Angela's going to speak a little bit about the advocacy piece, but I have to say, my 20 years of practice, I've never seen such a response from healthcare workers. So, within 3 days of the announcement, one of our colleagues in Ottawa, an infectious disease doctor, had a press conference to announce his concerns about it. A few days after the cuts were announced, we organized, there was a colleague of mine who works at St. Michael's Hospital, Phil Berger, and he called and he said, I've got an idea. I said, what is that, Phil? And he's a bit older. He said, in the 70s, this worked really well. I said, right. He said, okay, we're going to go occupy a federal government building. And I said, right, federal government building. Who is this? And it seemed a bit out there, but it certainly would engage the media. We were trying to get 12 physicians to walk into the office of a member of parliament and just draw some attention to this issue. We had 90. And when we left there, we decided we would try to engage one of our national colleges, so there's a College of Family Physicians who would help get involved. Within a week, there was a letter to Mr. Kenny from 8 national healthcare organizations, including the Canadian Medical Association. There's been 20 national organizations that have come out and asked the government to rescind or revise these cuts. This is unprecedented in terms of response from the healthcare community. And yet, we have heard nothing back from the government around our concerns. And this is a list of national organizations. You'll see pretty much every healthcare worker in the country is going to be covered by their organization. So we have the Canadian Medical Association, we have national organizations representing nurses, midwives, physiotherapists, occupational therapists, public health physicians, pediatricians, it just goes on and on. One that's not on there is Canadian Association of Emergency Physicians, who sent me a note a couple of days ago. And a number of these groups have asked Mr. Kenny for a meeting. They've sent a second letter. There still hasn't been a response. Moving forward, what we're trying to do is we're trying to document the impact of these cuts. So we have a number of cases that we have at our disposal right now. We're planning to issue a press release sometime in the next couple of weeks. We're really trying to engage new emerging communities in Toronto, new immigrant communities. There was a very eloquent letter by the Toronto Board of Rabbis speaking to the designated country of origin list, and we're hoping other communities can be brought into this discussion as well. And we're trying to continue to raise